Welcome back to the Pelvic Pod, proudly brought to you by Incontinence NZ. I'm Jen Bainbridge, and welcome back to the safe space that we've created to have conversations that most people are just too embarrassed to be having. It's bladder and bowel health. Welcome today to Dr. John Short, who's a urogynaecologist. John works at Oxford Women's Health in Christchurch, and his expertise spans so many areas, but particularly in the management of urinary incontinence, vaginal prolapse and endometriosis. Dr. Short is passionate about education and service improvement, and he joins me now. Welcome.
Hi.
Thank you for flying all the way from Christchurch to be with us today.
It's great to be here.
To talk to you. We had to talk to you. So for those who don't know what a urogynaecologist is, let's start with that. Because I was telling a girlfriend today, I'm interviewing a urogynaecologist, and she said, what's that?
Yeah. So it's basically the part of gynecology, so women's health, but that covers specifically issues with the pelvic floor. So mostly urinary incontinence, overactive bladder, and vaginal prolapse.
Right. So what made you go into that area?
Well, it's a really common question I get.
Yeah.
And, people think it's a bit of a joke sometimes and whatnot. But basically, it's a great area to work in because women come with these pretty horrible problems that, have a pretty bad effect on their quality of life. And we can fix them. So the job satisfaction is amazing.
Yeah, so I was just going to say that it's incredibly satisfying. So tell me about the women that you do see. So are they absolutely at the end of their tether? Or are they having some minor symptoms and thinking, oh, maybe I should get that looked at? Or are you seeing more that women are leaving it a really long time and coming to you when things are really bad? And when they are, what does that look like?
So there'll be women of all ages. There'll be women who their problems aren't necessarily too bad. They maybe only just had their first child and they're experiencing bladder problems for the first time. Or there's older women who will have put up with problems for years that have been dismissed as just part of a woman's lot as they've aged and had their children. So yeah, real variety, to be honest. I can't really say that there's a single stereotype.
And so they're having that urgency to go to the bathroom and they're thinking, I need to see somebody about this. This is becoming unmanageable.
Well, that's one of the problems, yeah. So there's overactive bladder, which covers the issues of urgency. That can be associated with incontinence as well. So these women have a really strong urge to go to the toilet that might come on really suddenly, and before they can get there, they might start urinating. That's often associated with going a lot more frequently during the day, and sometimes waking up at night more than is normal to go to the toilet. It's normal, obviously, to go the odd time at night, but multiple times is
so you're
a big
okay
problem.
with once a night? That's all right.
I don't think it's okay. That might be the wrong word. But as you age, it does become more common. So certainly at my age, it's apparently normal to wake up once a night. Yeah. And as you get older, it becomes more common. So at some ages in your 70s, it might be the normal thing to go twice. But part of the deal with any incontinence problem is that it's up to the individual to determine whether they're okay with it or not. And then if they're not, then that's when we can try and help. Yeah, so as well as the urgency problems, there's also something called stress incontinence. So that's leakage of urine associated with physical things that might trigger a rise in the abdominal pressure, which then puts pressure on the bladder and forces urine out. So that might be things as simple as coughing or sneezing, jumping on the trampoline, going for a run, or even just being dragged along by your dog, or walking downstairs, or sometimes even just standing up from a seat.
Is it just childbirth that's causing this in women?
Not just, but it does seem to be one of the biggest factors.
And does prolapse cause bladder issues as well, or is that separate completely?
I personally like to think of them as separate, and the treatments are often quite different, but there is a lot of overlap between the two. So a lot of women who have bladder problems, whether it's urgency or stress incontinence, will often have a prolapse as well.
Right.
But fixing one doesn't necessarily always solve the other. So sometimes you do think of them as separate problems.
Is there a way to prevent the prolapse?
So there's been a lot of argument and discussion over the years about the birth process. Caesarean section might be protective of the pelvic floor because obviously you're bypassing that normal birth process. But pregnancy itself can have an effect, and the pressure of the pregnancy, in simple terms, the weight of the pregnancy on the pelvis might cause some weakening of the pelvic floor. Forceps definitely seem to be associated more with pelvic floor trauma.
Oh, okay.
So there's a lot of a move to move away from the use of forceps because we know they can be more traumatic. But all these things, caesarean sections, for example, come with their own problems. So it's not necessarily a simple solution.
So would you say suction then absolutely all the way?
That's preferable as if that sort of assistance is needed during a birth, then the ventousal suction cup causes less trauma to the mother.
Didn't know that.
It might cause a bit more trauma to the baby, unfortunately.
Because it does with the head shape, doesn't it?
Yeah, it gives them a sort of cone head.
Didn't want to do that. We went for forceps,
no, it's not inevitable, of course, that it harms the baby, but overall the chance of that's quite low, but more so than forceps. And but each situation has to be judged on its own merits. So, there may be instances where forceps are more appropriate because the baby might need to be delivered quicker.
Yeah, right. I had no idea about that with forceps. That's fascinating. We're learning. That's what we're here to do. When women come to you feeling stuck or embarrassed, what do you tell them about what's possible?
Well, first of all, you've got to talk through their problem and what's going on with them. And then in terms of what's possible, I think the most important thing is that something is possible and improvement is possible, because over the years it's just become considered a normal thing that women have to put up with.
Yes.
It's a normal consequence of birth and aging and life, which whilst it's common, it doesn't have to be tolerated. So the simplest treatment or the initial treatment in a lot of cases will be physiotherapy. And certainly around the time of pregnancy and birth, doing pelvic floor physiotherapy is probably your best bet for prolapse prevention, for example. But it's also can be a good treatment, particularly for stress incontinence.
But this isn't funded though, right? So a lot of women wouldn't naturally go and do that as a preventive, would they?
So that's always been an eternal problem, is funding. So ACC now does provide cover for birth injuries. But, there's a process to go through to get approval with ACC. There are obviously physiotherapists who work at the hospitals that can get involved with those women with symptoms. And it's otherwise a bit hit and miss on health insurance and what's available in communities that will vary from locality to locality, I'm sure.
But you'd be seeing women who are dealing with not just an inconvenience, but almost a disability when it comes to their bladders in some cases, right?
Oh, in some cases, absolutely. Yeah, absolutely.
Yeah, and that's the thing that's so shocking about the funding or lack thereof. But so we talk pelvic physiotherapy as your first sort of option for what you can do. What is the most life-changing treatment that you're offering that you absolutely feel women should seriously consider? So,
as a rule, you'd always like them to see the physiotherapist first, because it's never a bad thing to know how to train your pelvic floor. There are a few other treatments. There are devices that can be placed in the vagina called pessaries that can sometimes help by putting pressure on the right anatomical spots to prevent leakage. But the best results do seem to come from surgery. It's just that surgery can be quite a big undertaking and isn't necessarily always straightforward.
First to the pessaries before we go on to talk about the surgery more in depth. How do they work? Do women put them in every day and remove them every day like they would a menstrual cup?
Sometimes. So it varies from person to person. So traditionally, certainly for prolapse, they've been kind of seen as a thing for the elderly. And traditionally, they would usually be left in all the time. and just have a checkup every 6 or 12 months to check that there's no problems arising.
Wow.
But yeah, it's okay to leave them for quite long durations.
Are they sitting really high up in the cervix or something like that?
Well, they're just inside the vagina, which is angulated a certain way. So
it doesn't affect your sex life, as
well.
I'm asking. I'm going to ask it. Someone's thinking it.
Well, it's interesting because a lot of women do report just leaving their pessaries in and having sexual intercourse.
Okay.
And for them, it seems to work.
Okay.
Yeah, it might seem strange, but for some people it works.
Okay.
Of course, you can teach a woman how to remove the pessary themselves and put it back in themselves, and there's the moon cup comparison,
or the dental dam, or similar concept to that, I guess.
Yeah. So some women, particularly younger women, tend to prefer taking them in and out more regularly and using them at certain times when their symptoms might be more bothersome. So if they have leakage, but it only happens when they're playing netball, they might use one of the specialist continence pessaries when they're playing netball, for example. And there's a whole range of different types of pessaries. There's loads of different types. And some of them do cause more problems than others, so are better taken out occasionally to give the vagina a rest.
Because I was going to say, would you not get an infection if you're just leaving something like that in there all the time?
Actual full-blown infection's pretty rare. Discharge is very common, but that's the body's reaction to something foreign being there. So quite thick discharge can be one of the problems. Ulceration of the vagina, which is one of the main reasons for a regular checkup. So that can cause bleeding. We do recommend, if you're having a pessary, that you use estrogen cream. So that helps thicken the vaginal skin and make it a bit more resilient to pressure from a pessary.
Oh, it's fun being a woman, isn't it? If you don't want to do a pessary and you think to yourself, look, I actually want to get this surgery, I'm so tired of feeling this way. What is that journey? What does it look like from your first consult to the actual surgery? What do you do in the surgery, and then how long is that recovery for the pelvic floor? So,
generally speaking, there are a few hoops that have to be jumped through for stress incontinence surgery. So every case currently has to be signed off. We have what's called a high vigilance process that was introduced by the Ministry of Health due to some problems a few years ago with certain types of surgery that were being done. So some of the kind of requirements do include seeing a physio and having a good course of physiotherapy, because that's your best chance of avoiding an operation for incontinence.
Is that sort of a couple of months of trying?
3 months is
3 months.
3 months is the recommended minimum. Then following that, we'll need to just make sure that there's nothing else that's going to be made worse by doing this surgery. So common problems might be worsening or inducing an overactive bladder and creating symptoms like urgency. And that's because the operations for incontinence will inevitably tighten up the pipe work and make the bladder need to work a little bit harder.
Right.
So there are tests called urodynamics that will be required to be done to assess the bladder function, and particularly how well the bladder empties, and to make sure that there's no signs of any blockages or impairments to bladder emptying that are going to be made worse by surgery. And then surgery itself, there's a few options. We do generally believe in a shared decision-making process. So giving the woman as much information as we can and talking through in as much detail as possible about how the operation works and what can go wrong. And it's quite important to establish the woman's priorities. So there are some operations, some procedures that are quite low risk, quite quick and easy to perform, quite easy to recover from, but don't necessarily have the best results compared to other procedures.
So what do you do in those surgeries?
So that one in particular that I'm thinking of there is something called urethral bulking. So we'll put a telescope in the urethra and just inject a collagen-like substance into the upper urethra to thicken it up a bit and narrow the pipe.
Yeah.
So that's quite quick and easy, and it works, or it achieves a satisfactory result, and that's determined by the woman.
Long term?
Not necessarily long term yet, because it's not been around that long, but achieves a satisfactory result, certainly in the short to medium term, of about 50%.
Okay.
Then there are bigger operations that do have higher results, so certainly 80 to 90% in the short term, and maybe 75% satisfaction longer term. But they're much bigger procedures with longer stays in hospital. And for those things, you generally recommend, or I would recommend anyway, about 6 weeks of minimising physical activity.
And what are you doing in those operations?
So the commonest one these days is called a sling procedure. So we'll take a strip of tissue from another part of the body. So traditionally that's come from the abdominal wall, from something called fascia. More recently we can take that from the leg.
Really?
And there's pros and cons to each. And just a strip of tissue to use as a sort of hammock that sits around the urethra, and that's put in place and adjusted to provide the support that's been lacking, and that hopefully with that support the leakage will be prevented.
And how long is that? So you're saying 80 to 90% success rate. Is that a long-term solution, or is it something you have to come back and get done again?
Only very occasionally would you need to do that again. There is always, with any of these procedures, there is always an inevitable deterioration over time. So 90% of women might be satisfied after 12 months. After 10 years, that might only be 75% of women are satisfied. So there are things you can do in the meantime, like physio and pelvic floor training, to improve your chances of being in that 75%. And but then inevitably some women might return with symptoms.
What about drugs? Taking any drugs to help with the urgency? So
urgency is a good one for drugs. Stress incontinence doesn't really have a lot of drug options, but certainly urgency. So
the difference between urgency and stress incontinence is?
So stress incontinence is just the leaking with coughing, sneezing, laughing, trampling. Urges that real strong sense that might come on suddenly, and you might not get to the toilet in time before it starts coming.
So the urge is responding well to drugs, the stress isn't?
There's not really any drugs for stress incontinence. Urge incontinence, there are drug options available. Estrogen cream can help. So the bladder is actually quite fond of estrogen. And putting estrogen cream in the vagina, because the bladder is really close to the vagina, helps get that estrogen there quickly and reliably. The other drugs, the most common ones in the past have been a class of drugs called anticholinergics. So they work on the nerve endings and reduce the transmission of nerve signals. So they affect the chemicals that carry messages or send signals from one nerve to a tissue.
Amazing.
They do have a lot of side effects though.
Yes, I've heard that about them.
So dry mouth, dry eyes, constipation, and a lot of women with bladder problems often have bowel problems as well. So constipation's not always popular with them. There are newer drugs that have much less side effects and work in different ways, but unfortunately they're not currently funded, and they cost, I think, in the region of about $150 a month to have a course of them.
It's terrible. So I was diagnosed with diverticulum 28 years ago, and I was put on one of those medications, and yes, the side effects were terrible, and I actually stopped taking it very quickly because the side effects were awful. So I know what you're talking about there.
Dry mouth can't be hard.
The dry mouth, being a chatterbox like me.
I'm not
very
commenting.
Calm right now, and I'm not. But being a chatterbox and then being a broadcaster, it doesn't really go very well with having a dry mouth.
Well, neither does rushing to the toilet though.
I know, and I'm still dealing with this issue, and that's why my next question is around Botox to the bladder, because that is quite effective, isn't it?
Yes, it is. So with overactive bladder and urge incontinence problems, you've got your medications, as we discussed. Sometimes there are behavioural training programs like and bladder retraining.
Like a naughty girl.
Well, yeah, almost. Yeah, I suppose. Yes. Yeah, and physiotherapists or continence nurses will help with them. There are some nerve stimulation treatments. But the other thing, if the behavioural side of things and the medication hasn't worked, Botox does become one of the next options. So that's injected into the wall of the bladder. So Botox stands for botulinum toxin. So it paralyzes a toxin that paralyzes the muscle in the bladder. And by injecting it in small amounts spread out over the wall of the bladder, you can induce a degree of paralysis, basically, that helps prevent the bladder spasm that might cause the urgency.
What if it works too well? And then you can't
pee. Yeah, so then the bladder does have to be emptied. So it usually would rely on catheters.
For how long?
Well, that can vary depending on the problem. Botox does wear off, so the need for a catheter will go away usually, but it can, it's usually only short term. It can be days or weeks in the short term, but and long term requirement will be quite rare after that.
All right, yeah. See, that is actually what puts me off was the catheter.
Yeah, I mean, having one left in all the time would be a bit daunting, but most women who need it for more than a week or two generally learn how to catheterize themselves.
Okay.
So they take a small catheter about the size of a pen and place that in themselves until the bladder's empty, and then just do that a few times a day.
And how long does that Botox tend to last for?
Oh, it does need to be repeated usually because it wears off, but you should. It's reasonable to expect at least a year in the first instance.
That's all right. Compared to a major surgery, of course, but
yeah.
It's the long-term solution we really are looking for, though, isn't it?
Yeah, but there are different problems you've got to consider. So incontinence isn't just one problem. There are different types that have different treatments.
And we were discussing before we started about the connection between bladder problems and endometriosis. Can you speak to that a little bit? Because that's very interesting. That was something I had as a teenager.
Yeah.
And then, had their laparoscopy at 16, have never had an issue with it ever again. So very lucky catching it early. But then displaying with this bladder thing at around 18, I'm thinking, was that connected in some way?
It's hard to say in your case, but endometriosis is a really interesting condition that we don't fully understand. So there's these little pockets of tissue outside the uterus that behave the same way as tissue in the uterus and goes through the same cycle.
Right.
And that causes irritation to the internal organs, often presenting with pain, particularly around period time.
Yeah. It was
but it's well recognised now that it causes an irritable bowel type picture, because it irritates the bowel, literally, and similar problems to the bladder. Okay. So in some patients who otherwise are exhibiting signs or symptoms of endometriosis, then it might be reasonable to look for that as a cause of the bladder problems and treat the endometriosis.
Yes, because I had a friend who had the surgery for the endometriosis and they found it all over the bladder, actually. Yeah, so it does affect anywhere in the pelvis. And sometimes even outside. Unreal. Yeah. So back to the pelvic surgery, the major pelvic surgery that you discussed around the sling. So what sort of period of time can someone expect to spend in hospital, and then what does that recovery look like in terms of getting back to work and basic activities? A week, and then you said about 6 weeks in total, or is it really long, hard recovery?
It's going to vary with the type of operation and with the type of job that you do. True. Basically, the time in hospital will vary between 1 and 3 nights, depending on how quick you bounce back recovery-wise. A lot of the instructions about recovery and the sort of 6 weeks resting and minimising activity, that's about letting everything heal up properly. So most women will feel a bit lousy maybe for about 2 weeks with pain and just the basic recovery, and then beyond that people will start to feel better, and certainly by the 4-week stage, women are often feeling quite good and wanting to get back into things, but they do need to take it easy for that full 6 weeks to give everything the chance of healing properly and giving the best long-term result. Doing nothing's not a great idea. Walking to your tolerance strikes a really good balance. So doing something but not doing too much. Work-wise, it does depend on your job. If you have an office desk job, some people might start getting back into things after 2 or 3 weeks. If it's a more of a physical job, then you might need the full 6 weeks.
And are you seeing a difference to the urinating aspects straight away, or is this at that 4-week mark that you talked about?
In terms of the result, no, you'd hope to see an improvement straight away.
Oh, wow.
Sometimes it can take a wee while for everything to settle down and the pelvic floor to sort of recover. So it's not necessarily a bad thing if it doesn't work straight away. So we would always give it time. But yeah, it's not unreasonable to expect that there might be some signs of improvement straight away. So
why should people come and see you?
Well, if you have a problem with a prolapse or urinary incontinence, and it's particularly if it's stopping you doing things that you enjoy, then that's a point at which it's reasonable to say, I don't want to put up with this anymore. I'd like to enjoy this aspect of my life and so have this problem solved.
Yeah, absolutely. Yeah, and so the education part is so important, isn't it? And that's why we're having these conversations. Yeah. Where is the system letting women down, though? I think you've probably already said it, really, with funding for things. That's probably a really key issue, isn't it? Yeah, well, unfortunately, we have rightly or wrongly, we have a system where it's okay for some if they can afford to pay or have health insurance and can afford private treatment. Those reliant on the public system, it is going through a really tough time at the moment, and there's quite long waiting lists for surgery. It might be quite hard to get in to see a physiotherapist because their services are quite stretched. So it is a bit rough for some, unfortunately. What's the one symptom that women should never ignore? Well, in terms of a waiting list,
in terms of the bladder, so there are generally with most things a few red flag symptoms. I think in relation to the bladder, it's probably blood in the urine.
Blood in the urine.
Blood in the urine. Yeah. So that would be a potential sign of bladder cancer.
Okay.
So anything with blood in it's not to be ignored. And same for blood in the bowel. As well. Yeah.
And so people can see you in private practice, obviously, but if you are concerned about any of these bladder symptoms, straight to the GP, get yourself into, if you have to, the public system, get on that waiting list.
Well, a GP is always the best starting point because they've got the bigger picture of your health and the broader knowledge of what's going on and all that sort of stuff. So, as a first port of call, GP is always best.
In your area of expertise at the moment, are you seeing any sort of new technologies that are emerging that might be sort of coming through soon, or any new types of surgeries that are being looked at in any way?
No, not really in this space, unfortunately. There have been a few things in the last maybe 20 or 30 years that have not necessarily lived up to their promise or caused other problems, so they're not necessarily being used anymore. So most of the surgeries that we're doing now are things we've been doing for quite a long time. So there's new things might come along every now and then, but we've got to be really careful to make sure that they've been properly researched and studied properly, and they live up to their promise before we go crazy doing them on everybody.
Absolutely.
Yeah.
What is your message to women? Any final thoughts on what you're doing, what women need to be doing better, prevention, anything like that you'd really like to get out there?
Well, I think the single most important thing is that you don't have to put up with incontinence. That's been a problem that's been accepted for a long time, and you don't have to put up with it. There are things that can be done to help. And the best thing you can do for prevention is pelvic floor exercises. Some women do need a bit of coaching in that. So if you can see a physiotherapist to get that initial coaching at the very least, then that's the ideal thing.
Yeah, and there's the Squeezy app now.
Yeah, there's all sorts of things like that.
YouTubers
all sorts
doing
of apps and toys.
There's one lady who goes like this every day. She pops up every day to remind you to do it, which is great.
Yeah.
There was something I learnt though in a previous interview with another pelvic physio that actually you should stand up and do the pelvic floor exercises. That's the best way to do them. I always thought you did them while you were sitting down,
Well, I've been doing one this whole time. Only joking.
But men should do them too, shouldn't they?
Men. It's definitely helpful for men if there's any men listening, sure.
Yeah.
But most problems occur when women are standing up. So it's very unusual for stress incontinence, for example, to happen when you sat down or lying down. Because
it's when you're moving around.
And the lack of the gravity makes a difference to the pressure. So when you stood up and active is when things can be most problematic. So there is some sense to that. Yeah.
Yes, absolutely. Yeah. But the men, especially the men who are into the heavy weightlifting, there's no harm in protecting the pelvic floor for that as well, right?
Well, weightlifting is quite popular with women now.
It is. I'm a squatter. I do squats, weighted squats now.
So you need to do your pelvic floor exercises.
I know. There's a lot I need to deal with my pelvic floor.
But it's an interesting...
This podcast has been a real wake-up call, trust me.
It's a good point, though, because there's something called pelvic floor safe exercises.
Yeah, right.
And there's a whole branch of exercise that involves weights and squats and running that, for various reasons, put added strain on the pelvic floor.
Yeah.
And can contribute to some of the problems. So a lot of women, for example, they'll describe their urine leaking when they're at the gym or when they're running.
Yeah.
And those activities, by putting extra strain, extra weight on the pelvis, or by the repeated bouncing and impact of running, put that added strain on. So someone's developed a whole thing called pelvic floor safe exercises.
Wow.
That you can, it's like if you just look on the computer on Google, that whole thing should come up of exercises that put less strain on the pelvic floor.
That's a great idea.
Yeah.
Yeah, because I go to the gym, when I'm in the gym, I go to the toilet maybe 4 times during a 1 hour workout.
Wow. Yeah, because you'll be drinking more as well. Because you'll be getting sweaty.
That's the other thing I've learnt, though, is that I actually probably am drinking too much water during the day, and probably most of us are. That we've been told at least 8 glasses of water. I have way more than that, actually. Yeah, I have way more than that. Yeah, so that's contributing.
The more you drink, the more you need to wee. So
100%. But it sounds like you're doing some amazing work out there, and I love that that you've been drawn to helping people so much with this issue, because it really is very debilitating, isn't it? And you must see amazing outcomes.
Brilliant feedback. People come back after procedures and they might have a few problems in the initial recovery, pain and things, and they might not enjoy their recovery necessarily, but once that's all done and dusted, the feedback's great. Rave reviews. Well, I think it makes a difference to people, and they can enjoy life again, I think.
And that's the life-changing work you're doing. Thank you so much for joining me today here on the Pelvic Pod. Dr. John Short, Urogynaecologist. You can see him at Oxford Women's Health. And do you do some public practice as well, or just in the private practice at the moment?
I served my time.
You've served your time?
No, I did. I left 2 years ago, so I worked in Christchurch Women's Hospital for about 18 years.
Go you. Yeah, you've done your bit. Well, thank you very much for making the trip to Auckland to see us here today to talk about this incredible surgery that you offer and all the other services that you do.
Thank you.
I really do appreciate it. And if you are in Christchurch again, you can reach out to John. Oxford Women's Health .co.nz. Also, the team at Incontinence NZ are on the helpline, and they're ready to talk to you anytime about this issue. There is no topic that they can't talk to you about. 0800 650 659. That is a great place to start your journey, or you can visit the website continence.org.nz. I'm Jen Bainbridge for the Pelvic Pod. Mā te wā.